Okay, probably can everyone hear me without the mic? Yeah, okay, let's go ahead with that. So thanks for having me here to speak. This is going to be talking about AI rather than policy for AI, but obviously a lot of the policy things are really important for this area. So we've been working on early detection of cancer from CT scans. And cancer is one of the number 2 killers of people everywhere. And for pancreatic cancer, for example, 5-year survival rate varies from less than 10% if you don't catch it early. Catching it early means when the tumor is less than 2 centimeters or smaller. Now, there's 80 million CT scans taken yearly in the United States, not looking for cancer, but those are places where you could run AI on, and you could do a lot of potential pre-screening for people who may not even be aware that they're sick. That's in addition to the people who are coming in to be treated with cancer. Now, radiologists can detect cancer from CT scans, but performance isn't really high for these things, and that's because it's extremely difficult. It takes really a lot of skill to do it. It's not easy at all. And AI is an advantage because AI CT scans are essentially 3-dimensional. AI can access 3 dimensions. Humans have to look at 2D images, and humans have not evolved to do that type of thing. And it motivates AI algorithms for doing this for both for early and pre-diagnostic, which is even earlier. This is a worldwide collaboration. I guess one of the main people involved in this is Songwei Zhao, who's here, and our good friends Kang Wang and Yang Yang at UCSF over here. And in terms of one thing about policy, I think is actually having data organized properly makes an incredible difference. And all this work that I'm going to present is largely because UCSF has got their act together with that. Okay. We collaborate with a whole lot of people all over the world, but mainly they're mainly for testing the algorithm. I should have to say that this looks like it's Johns Hopkins over here, but it isn't. We have a lot of data tested, but it's up in Boston, Mass General Hospital, Brigham Young Hospital. Okay, so PDACs, here's an image of them. So this is an early stage, less than 2 centimeters. Actually, it's close to 2 centimeters, I think. And there, the task of radiologists is to look in here and say there's a tumor. Not easy. I can't do it, and I've looked at these things for ages. If it's bigger, even I can see them, but for these early ones, they're really hard. Lots of them are missed. Over here, there is a tumor here. Whoever was looking at the scan did not see it. It's called pre-diagnostic. It's actually really hard to see, even with retrospect, even if you tell an experienced radiologist, there is a tumor, look at it carefully. I think most of them cannot do it. Okay, so that's the thing that you want to do, and how do you do it? Well, actually, I'm not going to go into the details. No equations in this talk. Here are the results we can get at the moment. For early stage, we work at sort of 94 sensitivity compared to the doctors here. This admittedly is on data from UCSF, tested on UCSF. If we do it on the other 7 sites or more, it goes down, but not by very much, and there are ways to improve it. Sensitivity, so 2 things. One is sensitive, one is, sensitivity is the issue. Okay, do you actually see it there? Specificity is a way of making sure you're not making too many mistakes and seeing tumors everywhere. So really what you want, ideally, is you need 99.99, 99.99. The algorithms are getting up there. This is all size tumors. These are bigger. Even people like me can see them sometimes. But detecting those for the pancreas, if you've got a tumor that size, your chances are not high. So this is what we can do now, and they say it's largely due to the UCSF people having their data organized. Well, we'll say a lot more about how they've done that, but it's good. Pre-diagnostic, okay, this would be even better. This would be, can you tell people who've got cancer before a radiologist can even see it. So these tumors may possibly be 2 centimeters, but they can't be much bigger. And even if they are 2 centimeters, they may not be visible because maybe the appearance is, different. No one quite knows. We're studying this, we're able to study it because the UCS people have got such good data. And we are not able to detect cancer all the time in these cases, detect the tumors, and in fact in these scans, maybe there aren't any. Fine, okay. But these things are very, generally very good compared to radiologists essentially zero on these. And can you detect it earlier? Maybe the cues for individual tumors or other things we're looking into. You can ask when Sharon, who's my student working on this, she can tell you. Okay, so that's on the CT scans, 4 minutes, right. Now another thing I want to mention is that's the pancreas. That's partly because there's a certain amount of public data where people have gone to the trouble of actually annotating the tumors. That's painful, takes a lot of time, requires expertise to do it. And do you want to do that for every possible tumor that you want to find in any organ? And so then again, thanks again to our UCSF people, there's the idea that you may not need that level of detail. Radiologists, when they study people, they prepare reports. The reports do not say exactly where the tumor is, but they say, hey, there's a tumor roughly in this position, okay, and rough size and a few other properties. That information is stored. UCSF, you can get, well, I don't know on pancreas, but 500 million scans for CT scans, these types of reports. And then the idea is you train the eye just using these reports. It's not as much information as using the, using the Tumors annotation, but you can go a very long way with it. And here is preliminary results, work in progress here on other organs, where I think there may be either a few mask annotations, a few meaning about 10, 15 or a bit more, but anyway, without that, just using the radiologist reports. Over here, performance on these organs here. This is human, so actually humans are not so bad on the prostate tumor, but on the others. These are not completely fair. These human responses are reported on other data, not on our data. We would like to do that. We need to do the studies. We need to persuade radiologists who are hardworking, haven't got much time, are expensive to do some of those things too. How to use these? Well, these would act for radiologists as an assistive tool. We do some studies about that. Will it help them in practice? And something we've come up with also is to prepare their reports for them automatically. That's something they have to do. It's a bit painful, so why not see if the AI can do it and just give them the report. They look at it, they edit it, they can manufacture it. So this is intending perhaps to take down the current time, which is about 5 to 10 minutes for radiology to look at the thing to report to, a small amount of time and hopefully not painful time at all. Other topics, 1 minute. Other things like, okay, can you use AI to mean that you can get much more out of your CT scans without radiation or throwing them out? CT scans take X-ray images. You want to reconstruct from that a 3D image. That's done with old-fashioned mathematics. If you do it with AI, so far you can get really good reconstructions with less series. Applies to going through airport security too. Not necessarily for the passengers, but for the people who use those things, apparently they get exposed to more radiation than is healthy. So summary from here, okay, 40 seconds. Detecting localized cancerous tumors in the abdomen, pancreas and other organs, focusing on early stage and pre-diagnostic, because that's where it would really help. We collaborate with radiologists, so we are aligned at least with the radiologists. Based on the first talk, not necessarily on the patients. There's a lot of technical stuff here. We don't just use off-the-shelf stuff. We develop our algorithms. We develop algorithms for synthesizing tumors, etc. A whole bunch of stuff's there. We use LLMs and all that sort of machinery as well and improve them. world models I mentioned here, this actually relates a bit to something coming up in the first talk about the idea of the AI being an agent within the bigger system. And so that's something we're moving on to a bit. The AI would be an agent, it would be you could manipulate the thing by putting in some sort of testing, some sort of manipulation, etc. But those concepts actually, which we're starting to do, we've only got one paper on that relates to that. Publications, we have a lot of publications that are out for people who are interested. I'm out of time, so I'll stop there. Thank you.